Welcome to Chapter 5 of our Retina and Vitrea series, where we will be covering diabetic retinopathy from end to end. Diabetic retinopathy is arguably the single most important vascular disease of the retina that you will encounter, both in clinic and on the board examination, and it is a topic that rewards a structured way of thinking rather than rote memorization. Over the course of this lecture, we will build that structure piece by piece. By the end, you should be able to stage any diabetic eye, predict its trajectory, and justify a treatment plan. Let us begin.
Let us start by placing diabetic retinopathy in its proper public health context. Diabetic retinopathy is a leading cause of vision loss worldwide, and it is important to appreciate exactly which patients it takes vision from. It most commonly affects patients between 25 and 74 years of age. This burden is particularly important in resource-rich countries, including the United States, where the prevalence of diabetes continues to climb. Now, before we go further, we need to distinguish the two forms of diabetes mellitus because they behave differently and, as we will see shortly, they carry different screening recommendations. Type 1 diabetes results from idiopathic or immune-mediated destruction of the pancreatic beta cells, and it usually leads to an absolute insulin deficiency. Because the beta cell mass is destroyed, the onset is typically abrupt and clinically obvious, which means the date of diagnosis closely approximates the date of disease onset. Type 2 diabetes, by contrast, is characterized fundamentally by insulin resistance, and it may occur with or without an accompanying insulin deficiency. Keep that distinction in mind because the insidious nature of type 2 disease, a body that is resistant to insulin long before anyone measures a glucose, will directly explain why so many type 2 patients already have retinopathy on the day they are diagnosed.
Before we discuss any epidemiology or pathophysiology, we need a shared vocabulary because the entire framework of diabetic retinopathy rests on one dividing line. That line is whether or not new blood vessels have grown beyond the retina. Nonproliferative diabetic retinopathy, abbreviated NPDR, is characterized by intraretinal vascular changes, meaning the pathology is contained within the retina itself. In NPDR, extraretinal fibrovascular tissue does not develop. NPDR is then staged by severity as mild, moderate, or severe, and we will spend considerable time later on the specific criteria that separate those tiers. Proliferative diabetic retinopathy, or PDR, is defined by the presence of retinal neovascularization occurring as a consequence of diabetes-induced ischemia. PDR represents the most advanced stage of diabetic retinopathy, and it may develop after progression through the sequential stages of NPDR. Clinically, PDR is staged into early disease and PDR with high-risk characteristics. In that second category, high-risk PDR is a formally defined entity with specific criteria that we will cover in detail because it is both a treatment threshold and a favored examination topic. For now, hold on to the essential concept. NPDR is disease confined within the retina. PDR is disease that has broken out of it. Everything else we discuss today will hang on that skeleton.
Diabetes mellitus is a growing global epidemic, and it is projected to affect 700 million people by the year 2045. Because retinopathy is a downstream consequence of diabetes, the prevalence of diabetic retinopathy is expected to increase correspondingly worldwide. Approximately 1/3 of all people with diabetes mellitus have some degree of diabetic retinopathy, and of those affected individuals, roughly 1/3 have a vision-threatening form of the disease. Much of what we know about the natural history of this disease comes from the Wisconsin epidemiologic study of diabetic retinopathy, universally referred to as Wester. The central finding of Wester was a direct association between longer duration of diabetes in both type 1 and type 2 and the prevalence of diabetic retinopathy. Duration of disease is, in other words, one of the most powerful predictors we have. Consider the 20-year mark. Among patients with a 20-year history of diabetes mellitus, 99% of those with type 1 disease and 60% of those with type 2 disease had some degree of diabetic retinopathy. That is a striking number for type 1 patients, essentially universal disease after 2 decades. When we look specifically at proliferative disease, 50% of patients with a 20-year history of type 1 diabetes had PDR, compared with 25% of patients with a 25-year history of type 2 diabetes. Notice that pattern. Type 1 patients accumulate both more retinopathy overall and more proliferative disease, and they do so faster.
Having established how common retinopathy is, the natural next question is how much vision it actually costs, and Wester gives us that answer as well. Visual acuity of 20/200 or worse, the threshold for legal blindness in the United States, was observed in 3.6% of patients with younger onset disease, defined as diagnosis before age 30, and in 1.6% of patients with older onset disease, diagnosed at age 30 or later. But the raw acuity numbers only tell half the story. The more revealing statistic is attribution. Vision loss was attributed to diabetic retinopathy in 86% of the younger onset group, but in only 33% of the older onset group. Think about what that means clinically. In younger patients, when vision is lost, the retinopathy is almost always the culprit. In older patients, the majority of vision loss comes from other competing causes, the age-related pathologies that accumulate in any older population. That should shape how you evaluate an older diabetic patient with decreased vision, because assuming the retinopathy is responsible will lead you astray 2/3 of the time. Finally, we must be honest about the limitations of Wester. It was first published in the 1980s, and its study population consisted largely of white patients of Northern European descent. Its findings are therefore not entirely applicable to other racial groups, which brings us directly to our next topic.
That limitation of Wester, a study population that did not reflect the diversity of the patients we actually treat, leads us to the question of health disparities in diabetic eye disease. Social determinants of health contribute to 3 related problems: an increasing incidence of diabetes in the United States overall, a disproportionate disease burden among racial and ethnic minority groups, and a disproportionate disease burden among low-income adult populations. These are not abstractions, they show up in the data. Looking at 2011 CDC data on the percentage of adults with diagnosed diabetic mellitus who reported visual impairment, 20.7% of Black patients reported visual impairment, compared with 17.1% of white patients and 15.6% of Hispanic patients. Understanding these disparities is essential because access to screening and to timely treatment is itself a modifiable risk factor for vision loss. Now, on a more encouraging note, there is genuine good news embedded in the epidemiology. Rates of diabetic retinopathy progression and vision loss have declined over time, and that decline is attributable to 2 parallel advances: improved systemic control of diabetes and improved treatments for diabetic retinopathy itself. Hold on to that dual theme because it recurs throughout this entire lecture. Every management discussion we have today has 2 halves: what we do to the eye and what happens systemically to the patient. Neither works as well alone.
We now turn from epidemiology to mechanism, and this is where the lecture really begins to cohere, because everything clinical that follows is downstream of what we are about to describe. The initiating insult is chronic hyperglycemia, which adversely alters a range of biochemical and molecular pathways within the retinal vasculature. Several specific changes are associated with this hyperglycemic state. There is increased inflammatory oxidative stress, there is an increase in advanced glycation end products, the irreversible modifications that occur when excess glucose reacts with proteins over time, and there is activation of the plasma kallikrein pathways and the protein kinase C pathways. Each of these operates through somewhat different chemistry, but they converge on the same final destination. These changes ultimately cause endothelial damage and parasite loss. Endothelial cells and parasites are the 2 cell types that constitute and support the retinal capillary, so their injury is the foundational lesion of the entire disease. Layered on top of this metabolic injury are contributing systemic and hematologic factors. Hypertension and hyperlipidemia may exacerbate the underlying diabetic pathology, which is one reason we care so much about blood pressure and lipid control in these patients. There are also hematologic abnormalities associated with both the onset and the progression of retinopathy: increased platelet adhesion, increased erythrocyte aggregation, and defective fibrinolysis. Notice that all 3 of these push in the same direction, towards sluggish flow and vascular occlusion within already damaged capillaries. Hold on to that idea of occlusion, because it is the bridge to our next slide.
Let us follow that endothelial and parasite injury forward into its structural consequences. At the level of the retinal capillary, we see basement membrane thickening together with the selective loss of parasites. Parasites provide structural support and regulate capillary tone, so their selective loss leaves the capillary both weakened and dysregulated. The consequence is capillary occlusion, and from that, retinal non-perfusion. Modern imaging allows us to visualize these changes with remarkable resolution. OCT angiography, or OCTA, and adaptive optics scanning laser ophthalmoscopy may reveal areas of vascular remodeling that would be invisible on clinical examination. Importantly, these vascular abnormalities occur in both the superficial and the deep retinal capillary plexuses, and they worsen with increasing severity of diabetic retinopathy, meaning the imaging findings track with the clinical grade. Now let us follow the process into late-stage disease, where two distinct pathways diverge from the same injured capillary bed. Along one pathway, endothelial barrier decompensation leads to serum leakage and retinal edema. This is the leakage pathway, and when it involves the macula, it produces diabetic macular edema, which will occupy the final third of our lecture. Along the other pathway, retinal ischemia, the product of all that capillary occlusion, causes increased intraocular VEGF production, and that increased VEGF leads to retinal neovascularization. This is the ischemia pathway, and it is what converts nonproliferative disease into proliferative disease. Leakage and ischemia. Two roads, one origin.
This slide consolidates everything we have just discussed into a single vertical cascade, and it is worth pausing on, because if you can recite this chain, you can reconstruct the entire disease from first principles. The figure presents a stepwise sequence of arrows descending down the slide. It begins at the top with chronic hyperglycemia, which leads to chronic inflammation, formation of glycation end products, and activation of pro-inflammatory pathways, which lead to endothelial damage through parasite os. Basement membrane thickening is also a hallmark of early diabetic retinopathy. From there, we arrive at capillary occlusion. Hyperglycemia increases platelet aggregation and leukocyte adhesion, causing capillary occlusion and retinal non-perfusion. Non-perfusion leads to endothelial barrier decompensation, which produces serum leakage and retinal edema. The cascade continues to retinal ischemia, which drives increased intraocular VEGF, and the chain terminates in retinal neovascularization. I want you to notice the architecture of this diagram. Every clinical finding we will discuss for the remainder of this lecture occupies a specific position along this cascade. Microaneurysms and dot blot hemorrhages sit near the top at the level of capillary injury. Cotton wool spots and intraretinal microvascular abnormalities sit in the middle at the level of occlusion and non-perfusion. Diabetic macular edema branches off at the serum leakage step, and neovascularization, with all of its complications as seen in PDR, sits at the very bottom. Likewise, every treatment we discuss intervenes at a specific point on this cascade. Glycemic control acts at the very top, panretinal photocoagulation acts at the ischemia step by reducing the ischemic burden, and anti-VEGF therapy acts at the second to last step by neutralizing the mediator itself. Memorize this chain, and the rest of the chapter organizes itself. Now that we understand the mechanism, let us catalog how that mechanism actually costs a patient vision, because this list is essentially a clinical translation of the cascade we just walked through. There are three broad categories. First, capillary leakage, which produces diabetic macular edema, or DME. This is the leakage arm of the pathophysiology, and it is the most common cause of vision loss in diabetic patients. Second, capillary occlusion, which produces macular ischemia. Note the important asymmetry here. Leakage we can treat effectively, while ischemia, permanently lost perfusion in the central macula, is essentially irreversible, which is why macular ischemia carries a much poorer prognosis. Third, and most extensive, are the sequelae arising from retinal ischemia. These follow directly from the VEGF pathway and include retinal neovascularization itself, vitreous hemorrhage when those fragile new vessels bleed, tractional retinal detachment when the accompanying fibrovascular tissue contracts, and neovascular glaucoma when the neovascular drive extends anteriorly into the iris and the drainage angle. Each of these ischemic sequelae will receive its own dedicated discussion later in this lecture. If the disease progresses along a predictable cascade, and if duration of diabetes is one of our strongest predictors, then rational screening should follow directly from those facts, and it does. Let us take each patient population in turn. In type 1 diabetes, advanced retinopathy is rare during the first 5 years after diagnosis. This makes sense given what we said earlier. Type 1 disease declares itself abruptly, so the diagnosis date is close to the true onset date, and there simply has not been enough hyperglycemic exposure yet to produce advanced disease. In type 2 diabetes, the situation is entirely different. Hyperglycemia may be present for years before the diagnosis is ever made, and consequently, many patients already have retinopathy at the time they are diagnosed. Finally, pregnancy is independently associated with progression of diabetic retinopathy, so pregnant patients require their own accelerated schedule. The table on this slide operationalizes all of this. For type 1 diabetes, the first eye examination occurs 5 years after diagnosis, with annual routine follow-up thereafter. For type 2 diabetes, the first eye examination occurs upon diagnosis, not 5 years later, again with routine annual follow-up, unless of course other pathology is noted that warrants more frequent follow-up. For pregnant patients with either type 1 or type 2 diabetes, the first examination should occur soon after conception and early in the first trimester. Their follow-up is then stratified by severity. Patients with no retinopathy through mild or moderate NPDR are seen every 3 to 12 months, while patients with severe NPDR or worse are seen every 1 to 3 months. The logic is consistent throughout. The interval shortens as the risk of progression rises.
Let us expand on pregnancy, since it is the one physiological state that demands its own screening paradigm. Pregnant patients with diabetes may require more frequent retinal evaluations than their non-pregnant counterparts, precisely because pregnancy accelerates progression. When high-risk PDR develops just before or during pregnancy, it generally requires photocoagulation treatment. That is, we do not simply observe and hope to reach delivery. There is, however, an encouraging counterpoint. Retinopathy may regress after delivery, so some of the acceleration seen during gestation is not permanent. The frequency of follow-up during pregnancy depends on several factors that you should be able to enumerate. First, the severity of the retinopathy at baseline. Second, the patient's history of blood glucose levels. Third, the adequacy of blood pressure control. And underlying all three is a single guiding principle: the need to identify worsening disease before vision loss occurs. That principle is worth emphasizing because it is the philosophical foundation of all diabetic eye screening. We are not examining these patients to document vision loss after it happens. We are examining them to intervene during the window when the disease is progressing, but the vision is still intact.
This table presents the comprehensive management table, which extends the screening schedule we just discussed by cross-referencing retinopathy severity against the presence of macular edema. The rows list the severity of retinopathy in ascending order, normal or minimal NPDR at the top to high-risk PDR at the bottom. Each severity level is then subdivided by the presence of diabetic macular edema, no DME, non-center involving DME, or center involving DME. Reading across the columns, the table gives the recommended follow-up interval in months. Rather than memorizing every cell, I want you to extract the patterns, because the patterns are what the table is teaching. First, follow-up intervals shorten progressively as you move down the rows. A patient with normal or minimal NPDR and no edema is seen annually, while a patient with severe NPDR or proliferative disease is seen every few months. Second, the presence of center involving DME collapses the follow-up interval to 1 month, regardless of the retinopathy severity. When non-center involving DME is present, they are seen every 2 to 6 months, depending on the severity of diabetic retinopathy it's associated with.
This slide addresses the systemic half of management, and it opens with the single most important statement in it. Optimal glycemic control is the most important factor in the systemic management of diabetic retinopathy. Intensive glycemic control does two distinct things. It reduces the risk of new onset diabetic retinopathy, and it reduces the progression of retinopathy that already exists. A crucial practical point follows. Even small but sustained reductions in hemoglobin A1C substantially affect retinopathy progression. That is a message worth carrying into the examination room, because patients who feel they cannot achieve perfect control often become discouraged and disengage entirely. The data say that partial improvement, sustained over time, is genuinely worthwhile. The current recommendation is a hemoglobin A1C below 7%. Beyond glucose, two other systemic parameters matter. Poorly controlled hypertension is associated with increased progression of diabetic retinopathy and with increased risk of diabetic macular edema,
which follows logically from what we know about barrier decompensation, since elevated hydrostatic pressure across an already incompetent capillary wall will worsen leakage. And elevated lipid levels are associated with an increased risk of vision loss from the hard exudates that accompany DME, since hard exudates are precipitates of plasma lipoproteins. Practically, this means that patients with extensive macular lipid deposits should undergo fasting lipid panel evaluation, with treatment of hyperlipidemia when indicated.
Beyond the three pillars of glucose, blood pressure, and lipids, several other systemic conditions can worsen diabetic retinopathy, and each is worth recognizing because each is potentially identifiable. Severe carotid artery occlusive disease may result in advanced proliferative diabetic retinopathy as part of the ocular ischemic syndrome. The mechanism here is intuitive. If the eye is already ischemic from microvascular disease, and you then superimpose reduced macrovascular inflow from a stenotic carotid, the total ischemic burden and therefore the VEGF drive rises accordingly. Advanced diabetic nephropathy may also exacerbate diabetic retinopathy, which is unsurprising since retinopathy and nephropathy are parallel microvascular complications of the same underlying disease. And anemia may exacerbate diabetic retinopathy as well, again through the common denominator of reduced oxygen delivery to a retina that is already hypoxic. The key takeaway box at the bottom of this slide summarizes the entire benefit of glycemic control, and it is worth stating each one explicitly. Improved glycemic control leads to decreased new diabetic retinopathy, decreased diabetic retinopathy progression, decreased severe NPDR and PDR, decreased diabetic macular edema, and a decreased need for photocoagulation. 5 distinct benefits from one intervention. With the systemic foundation established, we can now turn to the eye itself, beginning with nonproliferative disease.
We now enter the first major clinical section of this lecture, nonproliferative diabetic retinopathy.
In NPDR, the retinal microvascular changes are confined to the retina and do not extend beyond the internal limiting membrane, or ILM. That anatomic boundary, the internal limiting membrane, is the defining criterion, and I want you to fix it in your mind now, because when we discuss intraretinal microvascular abnormalities in a few slides, the entire distinction between IRMA and true neovascularization will come down to whether the vessels have breached this membrane. The characteristic clinical findings of NPDR include intraretinal hemorrhages, commonly called dot blot hemorrhages, microaneurysms, cotton wool spots, intraretinal microvascular abnormalities, or IRMAs, and lastly, venous dilation and beading. These 5 findings are not a random collection. Each one is a visible manifestation of a specific step in the pathophysiological cascade we constructed earlier. Over the next 2 slides, we will take each finding in turn and connect it back to that mechanism, because understanding why each lesion looks the way it does is far more durable than memorizing a list of names.
Let us now take the first 3 findings and connect each to its underlying mechanism. Microaneurysms are focal outpouchings of the retinal capillary walls, caused by parasite loss and weakening of the capillary endothelium. Recall from our pathogenesis discussion that parasites provide structural support to the capillary. When they are selectively lost, the wall balloons outward at focal points. Microaneurysms are therefore the earliest visible signature of that parasite loss, which is precisely why the presence of at least one microaneurysm defines the entry point into diabetic retinopathy. Dot blot hemorrhages are intraretinal hemorrhages resulting from leakage or rupture of the deep retinal capillaries and microaneurysms, occurring within the internuclear and outer plexiform layers. Their characteristic round, dot-like appearance is a direct consequence of that depth. In the compact, deeper retinal layers, blood is confined into a rounded configuration, in contrast to the flame-shaped hemorrhages that track along the nerve fiber layer more superficially. Cotton wool spots are localized infarcts of the retinal nerve fiber layer, caused by precapillary arterial occlusion that produces focal retinal ischemia and stasis of axoplasmic flow. In other words, a cotton wool spot is a small stroke of the nerve fiber layer, and its fluffy white appearance is accumulated axoplasm at the borders of the infarct. The fundus photograph on this slide illustrates these findings in a single eye. You can appreciate scattered small red dots distributed throughout the posterior pole. These are the microaneurysms in dot blot hemorrhages. Interspersed among them are several fluffy, white, indistinct lesions with feathery margins. These are the cotton wool spots.
We now complete our catalog of NPDR findings with the two lesions that carry the greatest prognostic weight. Venous beading is irregular venous dilation and constriction caused by chronic retinal ischemia. It reflects severe retinal hypoxia and signals an increased risk of progression to proliferative disease. Think of the vein as losing its uniform caliber under sustained hypoxic stress, taking on a segmented, sausage-linked appearance. Intraretinal microvascular abnormalities, or IRMA, are dilated intraretinal shunt vessels that develop adjacent to areas of capillary non-perfusion as a direct response to retinal ischemia. Conceptually, IRMA represents the retina attempting to reroute blood around a non-perfused capillary bed. And here is the critical distinction that we flagged earlier. IRMA remain within the retina and do not breach the internal limiting membrane. That is what differentiates IRMA from true neovascularization, which by definition extends beyond the ILM. This distinction matters clinically because misidentifying IRMA as neovascularization would incorrectly stage a patient as proliferative and could commit them to unnecessary treatment. The figure on this slide is a fundus photograph with two labeled arrows. One arrow points to venous beading, where you can see a retinal vein with visibly irregular caliber, alternating segments of dilation and narrowing along its course, rather than the smooth, uniform tapering of a normal vein. The second arrow points to IRMA, appearing as fine, irregular, tortuous vascular loops lying flat within the retinal plane. Notice that the IRMA does not have the frond-like, disorganized architecture of neovascularization we will see shortly. It remains a flat intraretinal network. Both of these findings also carry formal weight in staging, which is exactly where we go next.
We now formalize everything we have just described into the ETDRS severity scale, which is the standardized grading system for nonproliferative disease. Mild NPDR requires at least one microaneurysm. The findings may include a few intraretinal hemorrhages or microaneurysms, and, importantly, the eye must not meet criteria for moderate or severe NPDR.
Moderate NPDR demonstrates more extensive retinal lesions than mild NPDR, including increasing microaneurysms, intraretinal hemorrhages, cotton wool spots, venous beading, or IRMA, but it does not meet the ETDRS 421 criteria for severe NPDR. Moderate is therefore, in practice, the middle ground, more than a few lesions, but short of the 421 threshold.
Severe NPDR is defined by any one of the following three findings, and this is the 421 rule that you must know cold. Extensive dot blot hemorrhages or microaneurysms in all four quadrants, 2 quadrants of venous beading, or IRMA in one or more quadrants. Any single one of those three criteria establishes severe NPDR. Very severe NPDR is then defined by the presence of 2 or more features of the 421 rule. Let me point out the internal logic of this rule, because it makes it far easier to remember. The number of quadrants required decreases as the specificity of the lesion for ischemia increases. Hemorrhages are relatively nonspecific, so we require them in all 4 quadrants. Venous beading, which we just described as reflecting severe hypoxia, requires only 2 quadrants, and IRMA, which by definition marks the immediate margin of capillary non-perfusion, requires only 1. The rule is essentially ranking these 3 lesions by how strongly each one predicts impending ischemic decompensation.
The table on this slide gives the risk of progression to high-risk proliferative diabetic retinopathy for the 2 most advanced non-proliferative categories. For severe NPDR, the risk of progressing to high-risk PDR is 15% at 1 year, rising to 60% at 3 years. For very severe NPDR, the risk is 45% at 1 year. Let me draw out the implications. First, compare the 2 1-year figures directly, 15% for severe disease versus 45% for very severe disease. Meeting a second criterion of the 421 rule triples the 1-year risk. Second, look at what happens to severe NPDR over time. 15% at 1 year becomes 60% at 3 years. So a patient with severe NPDR whom you elect to observe has more likely than not developed high-risk proliferative disease within 3 years.
These numbers are the quantitative justification for the shortened follow-up intervals we saw in the management table earlier, and they are the reason we begin to consider treatment at the severe NPDR stage rather than waiting for neovascularization to appear.
Underlying every one of those progression statistics is a single process, the accumulation of retinal non-perfusion. So let us examine it directly. Retinal capillary non-perfusion is common in advanced NPDR, and closure of the retinal arterioles may expand areas of non-perfusion and thereby increase overall retinal ischemia. This is detected with fluorescein angiography, where non-perfused retina appears as dark hypofluorescent areas devoid of the normal capillary filling pattern. Notably, non-perfusion may even be seen in cases of mild NPDR, a reminder that the angiographic burden of disease often exceeds what we appreciate on clinical examination. Macular vessel density decreases with increasing retinopathy severity, and these changes occur in both the superficial and the deep capillary plexus, consistent with what we discussed in the pathogenesis section. On fluorescein angiography and OCT angiography, one particular structure serves as a sensitive marker of macular perfusion, the foveal avascular zone, or FAZ. As disease progresses, the FAZ may become increasingly irregular, and it enlarges as the innermost capillaries surrounding it become non-perfused. The normal FAZ area is approximately 350 micrometers squared, though this measurement is highly variable between individuals, which is why serial comparison within the same patient is often more informative than comparison against a population norm. The figure on this slide is a high magnification angiographic image of the central macula, displayed in grayscale. At the center, you can see the foveal avascular zone as a dark vessel-free region, surrounded by the fine perifoveal capillary network that forms its border. Notice that the margin of this zone is not a smooth circle. The border appears ragged and irregular, with focal areas where the terminal capillaries have dropped out, enlarging and distorting the zone. That irregularity is the angiographic signature of macular ischemia. And recall from our list of causes of vision loss that macular ischemia is the one mechanism for which we have no effective treatment.
Let's now address management. First-line management is exactly what we described in the systemic section. Optimize blood glucose, lipid, and blood pressure control. That remains the foundation at every stage of this disease. Beyond systemic optimization, early panretinal photocoagulation, or PRP, can be considered in a specific subset of patients, those with severe NPDR or worse, those with type 2 diabetes, and those with a poor likelihood of adherence to follow-up or to systemic control. Anti-VEGF therapy can be used at all stages of NPDR, and it accomplishes two things. It reduces vision-threatening complications, and it actually improves diabetic retinopathy severity, meaning the disease can be made to regress along the severity scale, not merely held in place. Aflibercept and ranibizumab are FDA approved for diabetic retinopathy, including NPDR without macular edema. However, and this is an important nuance, routine early anti-VEGF treatment for NPDR without DME remains uncertain because a clear long-term visual benefit has not been demonstrated. In other words, we can improve the anatomy and the severity score without necessarily improving what the patient sees. Finally, intravitreal steroids can be used for the treatment of DME and may slow the progression of diabetic retinopathy as well. That tension between anatomic improvement and visual benefit is exactly what the trials on the next slide were designed to address.
Let us examine the two trials that define our current understanding of anti-VEGF therapy in nonproliferative disease. The first is DRCR Retina Network Protocol W. In this trial, aflibercept was found to reduce the cumulative probability of developing center-involved diabetic macular edema with vision loss and of developing proliferative diabetic retinopathy. The magnitude of that risk reduction was nearly threefold compared with sham injections after 2 years. A threefold reduction in the risk of developing the two most consequential complications of this disease is, on its face, a striking result. The second trial is Panorama, which studied moderately severe to severe NPDR. In that population, 50 to 60% of eyes improved by 2 or more ETDRS severity levels with aflibercept. Recall the severity scale we just walked through. A 2-step improvement means an eye moving, for example, from severe NPDR back toward mild disease. That is genuine regression of retinopathy, not simply arrested progression.
And yet, despite these improved anatomical outcomes, neither Protocol W nor Panorama demonstrated visual acuity gains at 2 years in eyes with good baseline vision. This is the central lesson of both trials, and it is worth sitting with. We can measurably improve the retina's appearance and reduce the incidence of downstream complications, but in an eye that already sees well, we have not yet shown that this translates into better vision at 2 years. This is precisely why routine early anti-VEGF for NPDR without DME remains an area of uncertainty rather than a standard recommendation.
We now cross the dividing line that has organized this entire lecture. Let's now discuss proliferative diabetic retinopathy.
Let us trace the transition from non-proliferative to proliferative disease. Progressive capillary damage and retinal non-perfusion increase retinal ischemia. This is the accumulating burden we discussed when reviewing angiographic non-perfusion. That retinal ischemia then stimulates the release of vasoproliferative factors, particularly vascular endothelial growth factor, or VEGF. VEGF, in turn, promotes neovascularization at 3 anatomic locations: the retina itself, producing neovascularization elsewhere, or NVE, the optic nerve head, producing neovascularization of the disc, or NVD, and the anterior segment, producing neovascularization of the iris and of the angle, abbreviated NVI and NVA, respectively. This neovascular response is the major source of diabetes-related ocular complications, including neovascular glaucoma, vitreous hemorrhage, and retinal detachment. I want to emphasize the conceptual elegance and the clinical tragedy of this process together. The retina is doing something entirely rational. It is hypoxic, and it releases a growth factor to build new vessels. The problem is that the vessels it builds are structurally incompetent. They are fragile, they leak, and they arrive accompanied by fibrous tissue that contracts. The retina's attempted solution is the source of nearly all of the blindness in this disease. The image on this slide is a fundus photograph demonstrating proliferative disease, showing an abnormal network of fine, irregular new vessels arising from the retinal surface. Note the disorganized frond-like branching pattern, which is quite distinct from the orderly dichotomous branching of the normal retinal vasculature. Also note the large area of capillary non-perfusion, marked by the red arrow, noted as a dark hypofluorescent background. Since VEGF is released into the vitreous cavity and diffuses throughout the eye, neovascularization can appear at several distinct anatomic sites, as mentioned in the previous slide. NVD is defined as new vessels located on the optic nerve head, or within 1 disc diameter of it. NVE refers to neovascularization elsewhere, that is, any neovascularization outside the optic disc region. NVI refers to neovascularization of the iris, and NVA to neovascularization of the angle. This slide displays several clinical photographs illustrating these entities. The bottom right picture shows a fundus view of NVD and NVE. The top right picture, labeled NVI, is an anterior segment photograph showing the iris surface with fine, irregular vessels coursing across it. Note that these vessels do not follow the normal radial architecture of the iris vasculature, but instead wander irregularly across the surface, which is what distinguishes pathological rubeosis from normal iris vessels. The bottom left image, labeled NVA, is a gonioscopic view of the drainage angle, showing new vessels crossing the structures of the angle. These are exam findings you should look for in every diabetic patient, as they are the hallmark of proliferative diabetic retinopathy. Neovascularization is not a static finding. It evolves through a predictable sequence. In the early stage, fine new vessels with minimal fibrous tissue extend beyond the internal limiting membrane, often using the posterior hyaloid as a scaffold. That detail about the posterior hyaloid is mechanistically essential. The new vessels do not grow into empty space. They grow along the back surface of the vitreous. This anatomical relationship is what sets up every traction-related complication that follows. In the progressive stage, the neovascularization enlarges with an increasing fibrovascular component. The lesion is now not merely vascular, but fibrous, and fibrous tissue contracts. In the late stage, the new vessels regress, but residual fibrovascular tissue remains tethered to the posterior hyaloid. This is a critical and somewhat counterintuitive point. Regression of the vessels does not mean resolution of the danger. The fibrous scaffold persists, still adherent to the vitreous,
and it is that persistent adhesion which continues to exert traction on the retina. The images on this slide illustrate this progression, showing fundus photographs of fibrovascular proliferation at different points along its evolution. In the earlier image, you can appreciate delicate vascular networks with little accompanying white tissue, while the later image demonstrates a denser lesion with prominent whitish fibrous membrane accompanying the vessels. As we move through the treatment sections, keep this staging in mind because it explains why treating an eye with extensive fibrovascular proliferation carries real risk of inducing traction, a phenomenon we will address directly.
The information of this slide is highly board-tested. High-risk PDR is defined by any one of the following three findings. First, any NVD accompanied by vitreous or preretinal hemorrhage. Second, NVD measuring 1/4 disc area or greater, with or without vitreous or preretinal hemorrhage. Third, NVE measuring 1/2 disc area or greater, accompanied by vitreous or preretinal hemorrhage. Notice the internal logic. Neovascularization of the disc is treated as more dangerous than neovascularization elsewhere. NVD qualifies as high risk with any hemorrhage regardless of its size. NVE, by contrast, must be both larger, 1/2 disc area, and accompanied by hemorrhage. So the hierarchy is, disc neovascularization is worse than peripheral neovascularization, and the presence of hemorrhage lowers the size threshold required. High-risk PDR carries a 50% chance of severe vision loss within 5 years without intervention, and it therefore warrants immediate treatment. Compare that number to the progression risks we reviewed for NPDR. This is no longer a question of risk of progression, but a coin flip on severe vision loss itself. This is why high-risk PDR functions as a treatment threshold rather than merely a descriptive category. Given a 50% risk of severe vision loss, the imperative to treat is clear, and fortunately, treatment has been shown to dramatically reduce both severe vision loss and the risk of complications. There are two main treatment modalities. The first is intravitreal anti-VEGF therapy, which neutralizes the mediator driving the entire proliferative process. The second is panretinal photocoagulation, or PRP, which works by an entirely different mechanism. It destroys ischemic retina, which reduces oxygen demand and thereby reduces VEGF production. Consider how differently these two treatments act. Anti-VEG therapy intercepts the signal after it has been produced. PRP eliminates the tissue that is producing the signal in the first place. The goals of treatment, regardless of modality, are 4: to control retinal ischemia, to reduce intraocular VEGF levels, to promote regression or involution of the existing neovascularization, and to reduce the risk of vitreous hemorrhage. The image on this slide shows a fundus photograph of an eye that has undergone PRP, noted as hundreds of discrete, round laser burns distributed across the peripheral retina, designed to sacrifice peripheral ischemic tissue in order to protect central vision.
Before we compare treatment modalities in detail, let's address the complications that may arise from treatment with anti-VEGF or PRP, the first including contraction of the fibrovascular membrane. Recall from our discussion of the stages of fibrovascular proliferation that fibrous tissue remains tethered to the posterior hyaloid even after the vessels themselves regress. When that fibrovascular tissue contracts, several things can follow. It may cause increased vitreoretinal traction, known as the crunch phenomenon. It may cause recurrent vitreous hemorrhage as contraction pulls on the fragile vessels within the membrane. It may cause tractional retinal detachment, or TRD, when the contractile force is sufficient to pull the retina off the underlying pigment epithelium. And it may cause a combined tractional and regmatogenous retinal detachment, if that traction becomes strong enough to tear the retina and create a break. When these complications occur, vitreoretinal surgery may be required, specifically for vitreous hemorrhage and for tractional retinal detachment. Specific injection-related complications may include retinal tear or detachment, as well as infection, such as endophthalmitis.
The evidence underpinning anti-VEGF therapy for proliferative disease comes principally from two trials. DRCR.net Protocol S compared panretinal photocoagulation against intravitreal ranibizumab alone. The headline finding was that visual acuity was equivalent between the two arms at both 2 and 5 years.
That equivalence is itself remarkable. It established that an injection-based strategy could substitute for what had been the definitive treatment for decades. Beyond acuity equivalence, ranibizumab demonstrated several specific advantages: better average vision during the first 2 years, less peripheral visual field loss, lower vitrectomy rates, and fewer cases of vision-threatening diabetic macular edema. Let me connect two of those to mechanism. The reduced peripheral field loss makes complete sense, because PRP works precisely by destroying peripheral retina, so field loss is not a complication of PRP so much as an inherent cost of its mechanism. And the reduction in vision-threatening DME follows from the fact that VEGF drives vascular leakage as well as proliferation, so an anti-VEGF agent addresses both arms of our pathophysiologic cascade simultaneously. Importantly, there were no differences in major cardiovascular adverse events between the groups. The critical caveat, however, is this: most eyes still required injections at 5 years. This is the durability problem, and it is the single most important practical consideration when choosing between these modalities. The second trial, Clarity, found that aflibercept produced superior visual outcomes at 1 year compared with PRP, reinforcing the same overall message.
Anti-VEGF therapy has applications in diabetic eye disease beyond the treatment of posterior segment neovascularization. It promotes regression of anterior segment neovascularization, that is, the NVI and NVA we identified earlier, and it can therefore be used in the treatment of neovascular glaucoma. However, long-term control of anterior segment neovascularization is better achieved with PRP. This is the durability theme again, and it recurs consistently. Anti-VEG gives you rapid regression. PRP gives you lasting control. In neovascular glaucoma specifically, this makes anti-VEG an excellent means of buying time while definitive treatment is arranged. Anti-VEG is a useful adjunct before vitrectomy, where it reduces the vascularity of fibrovascular membranes and thereby makes surgical dissection less hemorrhagic. Note that anti-VEG should be administered within 1 week before surgery in order to minimize the risk of vision-impairing tractional retinal detachment. This timing requirement follows directly from the crunch phenomenon we discussed. If you inject and then wait too long before operating, the fibrovascular tissue has time to contract, and you may arrive in the operating room facing a tractional detachment that did not exist before you made the injection.
There is a further consideration in anti-VEGF therapy that is less about pharmacology and more about the patient in front of you, and it may be the most clinically consequential point in this section. Patients receiving anti-VEGF therapy should adhere to near-monthly follow-up visits during the first 1 to 2 years. Missed follow-up may result in recurrent retinal neovascularization or irreversible vision loss. That is a demanding commitment, roughly a dozen visits a year, sustained across 2 years, for a patient population that frequently faces transportation barriers, competing medical appointments, and unpredictable systemic illness. Consequently, PRP may be preferred in patients with medical instability, with a poor likelihood of adherence, or with other barriers to follow-up. And here is the compensating advantage of PRP. Its effects may last for decades. One treatment course, decades of effect, versus monthly injections with irreversible vision loss as the penalty for missing them. Reasonable clinicians select different modalities for different patients on exactly this basis. Finally, the two treatments can be combined, and the rationale for combination therapy synthesizes everything we have discussed. Anti-VEGF provides rapid regression of neovascularization and may reduce the onset or worsening of diabetic macular edema. PRP provides durable long-term control without requiring long-term intravitreal injections. Used together, you capture the speed of one modality and the permanence of the other.
Let us now turn to panretinal photocoagulation in its own right. Historically, PRP was the mainstay of PDR treatment before the advent of anti-VEGF therapy, and its indications are largely based on findings from the Diabetic Retinopathy study, or DRS. Even in the modern era, PRP is almost always recommended for patients with high-risk PDR who are not already receiving anti-VEGF therapy, so it remains a first-line treatment, not a historical artifact. The mechanism of action deserves careful attention because there are actually two distinct mechanisms operating simultaneously. The first is straightforward ablation. PRP ablates ischemic retina, which results in decreased production of VEG and other growth factors, regression of existing neovascularization, and prevention of progressive neovascularization.
The second mechanism concerns oxygen tension, and it is more subtle. PRP increases intraocular oxygen tension in two ways. First, by decreasing retinal oxygen consumption through the purposeful destruction of retinal tissue, fewer metabolically active photoreceptors means less oxygen demand. Second, by increasing oxygen diffusion from the choroid through the photocoagulation scars themselves. The laser scar creates a low-resistance pathway, allowing choroidal oxygen to reach the inner retina more readily. So PRP does not merely eliminate the ischemic tissue producing VEG, it actively improves oxygenation of the retina that remains. That dual mechanism is why the effect is so durable, and it is precisely the kind of two-part explanation that examinations favor.
This slide presents the graphical evidence from the diabetic retinopathy study that established photocoagulation as effective therapy. The horizontal axis represents years of follow-up, extending from 0 out to 5 years, whereas the vertical axis represents the cumulative rate of severe visual loss, expressed as a percentage. Plotted on the graph are the control eyes, which received no photocoagulation, and treated eyes, which received PRP. The control curves rise steeply and continuously, reaching substantially higher rates of severe visual loss by year 5. The treated curves, by contrast, rise far more gradually and flatten out over time, remaining well below the control curves at every time point. This graph explains why panretinal photocoagulation became the standard of care and why it remains one of the first-line options today.
Let us now discuss how PRP is actually performed. The standard technique, derived from the DRS and ETDRS protocols, calls for at least 1,200 laser burns, using a 500 micron spot size, with burns separated by half a burn width, delivered with an argon green or blue-green laser. Pattern scan lasers, which deliver burns in rapid preset arrays, are widely used, but uncontrolled studies suggest that pattern scan lasers are not equivalent to conventional PRP on a burn-for-burn basis, meaning that if you use a pattern scan laser, more burns may be required to achieve an equivalent effect. There are several technical pearls worth knowing. Spare the horizontal meridians, which carry the long ciliary vessels and nerves. Sparing these structures preserves accommodation, pupillary function, and corneal innervation. When heavy treatment is necessary, prefer the inferior retina, because visual field loss inferiorly is less noticeable to the patient than superiorly. The corresponding superior field defect is less intrusive than an inferior one would be. More broadly, treat areas associated with lower morbidity. Avoid foveal photocoagulation at all costs, and be particularly careful when using image-inverting lenses, where disorientation about the location of the fovea can lead to catastrophic error. Finally, wide-field fluorescein angiography can demonstrate the areas of non-perfusion, and thus guide selective placement of PRP, an approach that targets treatment where the ischemia actually is, rather than treating uniformly.
Because PRP achieves its benefit through deliberate destruction of retinal tissue, it carries an expected profile of adverse effects, and it is useful to divide these into those that persist and those that are transient. Among the ocular complications are choroidal detachment, decreased peripheral visual field, decreased night vision and color vision, and decreased contrast sensitivity. Rarely, pupillary dilation may occur, which connects back to the technical pearl about sparing the horizontal meridians and the long ciliary nerves. PRP may also worsen macular edema, and this is a particularly important point clinically because it directly informs treatment sequencing in patients who have both proliferative disease and macular edema. We will return to that sequencing issue in the DME section. The transient adverse effects include loss of 1 to 2 lines of visual acuity, increased glare, loss of accommodation, loss of corneal sensitivity, and photopsias. Notice that several of these transient effects, accommodation and corneal sensitivity in particular, mirror the function served by the long ciliary nerves, again reinforcing why meridional sparing is part of good technique. When you counsel a patient before PRP, these are the effects to discuss honestly. Patients who are not warned about diminished night vision and peripheral field are often distressed by changes that are in fact an expected consequence of a treatment that saved their central vision. When medical and laser therapy prove insufficient, or when structural complications supervene, we move to surgery. Pars plana vitrectomy, or PPV, has a defined set of indications in PDR, and each one reflects a problem that cannot be solved by injection or laser. The indications are as follows. Non-clearing vitreous hemorrhage, or dense premacular subhyaloid hemorrhage, blood collected directly in front of the macula, are two main indications. Tractional retinal detachment involving or threatening the macula, combined tractional and rhegmatogenous retinal detachment, red blood cell-induced glaucoma, also termed erythroclastic glaucoma, or ghost cell glaucoma, where degenerated red blood cells obstruct the trabecular meshwork, are other indications. And finally, anterior segment neovascularization with media opacity preventing PRP, a situation in which the eye urgently requires panretinal photocoagulation, but you cannot see well enough to deliver it, so vitrectomy is performed to clear the media and permit treatment.
We now turn to the vision-threatening complications of diabetic retinopathy, which includes neovascular glaucoma, vitreous hemorrhage, tractional retinal detachment, diabetic papillopathy, and diabetic macular edema. Let's get started.
Neovascular glaucoma is a severe form of glaucoma characterized by abnormal blood vessels within the drainage angle, which lead to synechial angle closure and, consequently, glaucoma. Let me walk through that sequence because the mechanism dictates the urgency. New vessels grow across the angle structures. Those vessels are accompanied by a fibrovascular membrane. That membrane contracts, dragging the peripheral iris into opposition with the trabecular meshwork and forming peripheral anterior synechiae. Once the angle is closed, aqueous outflow is mechanically obstructed and the interocular pressure rises, often dramatically. Clinically, the management depends on the extent of the neovascularization. Small isolated tufts of new vessels at the pupillary border may be monitored.
However, contiguous neovascularization of the pupil or the iris collarette requires urgent treatment. The definitive treatment is PRP, which follows logically since the driver is posterior segment ischemia, and we must eliminate the VEGF source rather than merely address its effect anteriorly. Anti-VEGF therapy may be used as a temporizing measure until PRP can be performed, consistent with what we said earlier about anti-VEGF providing rapid but less durable control. Finally, persistent peripheral anterior synechiae despite PRP and anti-VEGF may require glaucoma surgery because once the angle is permanently scarred closed, removing the neovascular stimulus cannot reopen it. The photograph on this slide is a slit lamp anterior segment image demonstrating iris neovascularization. You can see fine, irregular vessels coursing over the iris surface and toward the pupillary margin, which is the clinical appearance of iris rubeosus.
Vitreous hemorrhage is among the most common presentations of proliferative diabetic retinopathy, and the question of when to operate was addressed directly by the Diabetic Retinopathy Vitrectomy Study, or DRVS. The DRVS compared early vitrectomy, performed at 1 to 6 months, against late vitrectomy, performed at 1 year, in patients with severe PDR and vitreous hemorrhage. The results differed strikingly by diabetes type. In type 1 diabetes, early vitrectomy provided a clear benefit. In type 2 or mixed diabetes, there was no clear benefit to early intervention. Several clinical management principles follow. Consider earlier vitrectomy in patients with PDR who have not had prior PRP, since these eyes have an untreated ischemic drive and are likely to continue bleeding. Conversely, patients with complete, well-placed PRP may be observed longer before intervention because their proliferative process has already been addressed. Dense, non-clearing vitreous hemorrhage requires frequent ultrasonography to monitor for retinal detachment. This is essential because when you cannot see the retina, ultrasound is your only means of knowing whether it remains attached. If a detachment is present, the timing of vitrectomy depends on the characteristics of that detachment, including whether it's MAC on or MAC off. In bilateral severe vitreous hemorrhage, perform vitrectomy in one eye as soon as possible for visual rehabilitation, since a patient with bilateral dense hemorrhage is functionally blind. Finally, smaller gauge vitrectomy systems have shortened operative times, reduced complications, and allowed earlier intervention than was possible at the time the DRVS was conducted. The fundus photograph on this slide shows an eye with vitreous hemorrhage, with the retinal view partially obscured by blood in the vitreous cavity, producing a hazy, indistinct view of the underlying retinal detail.
Tractional retinal detachment is the direct structural consequence of the fibrovascular proliferation we described earlier, and its pathogenesis brings together several threads from this lecture. Vitreous attachment to fibrovascular tissue can exacerbate traction and cause a secondary tractional retinal detachment. A partial posterior vitreous detachment increases traction on the neovascular tissue and can produce vitreous or preretinal hemorrhage. Note the important nuance here. It is the partial PVD that is dangerous. A complete posterior vitreous detachment would release the retina entirely. It is the incomplete separation, with the vitreous still adherent at points of fibrovascular attachment, that confers higher risk. The potential complications include vitreous hemorrhage, retinal schisis, macular heterotopia or macular drag, meaning displacement of the macula from its normal anatomic position by contractile forces, progressive fibrovascular proliferation, and retinal breaks leading to a combined tractional and rhegmatogenous retinal detachment. Management depends critically on macular involvement. A TRD not involving the macula may remain stable for years without any treatment, and observation is appropriate. But a macula-involving or macula-threatening TRD generally warrants prompt vitrectomy. The fundus photograph on this slide demonstrates a tractional detachment, showing elevated retina drawn up toward fibrovascular tissue, with the characteristic taut kempted configuration and visible fibrous membranes exerting traction on the retinal surface.
Diabetic papillopathy stands somewhat apart from the complications we have just discussed, because it is not primarily a consequence of neovascularization. It presents as unilateral or bilateral optic nerve head edema, and it may be associated with diabetic macular edema, resulting from increased vascular leakage in the peripapillary region. Two risk factors are described. The first is a small cup-to-disc ratio, the so-called disc at risk, where a crowded optic nerve head has limited space to accommodate any swelling. The second is rapid reduction of glycemia, which is a striking and clinically important association, since it means that aggressive correction of hyperglycemia can itself precipitate this condition. Regarding prognosis, diabetic papillopathy can occur at any stage of diabetic retinopathy and at any level of glycemic control, so it does not require advanced retinopathy to develop, and its presence does not imply severe disease elsewhere. There is no proven therapy for it. Nonetheless, it generally carries a good prognosis, which distinguishes it sharply from nearly every other complication we have covered today. The essential clinical caveat is that diabetic papillopathy is a diagnosis of exclusion. You must rule out the other causes of optic disc edema before attributing swelling to diabetes. Given the differential for a swollen optic nerve, that is not a step to be taken lightly. The photograph on this slide shows an optic nerve head with disc edema, demonstrating blurred and elevated disc margins, with loss of the normal sharp demarcation between the disc and the surrounding retina.
Let's now discuss diabetic macular edema, which returns us to the leakage arm of the pathophysiologic cascade we constructed at the beginning of this lecture. The pathophysiology proceeds as follows. Hyperglycemia causes breakdown of the blood-retina barrier. That breakdown results in fluid extravasation from retinal vessels, most commonly microaneurysms, into the surrounding neural retina. This process may be associated with hard exudates, which are precipitates of plasma lipoproteins, and which may persist even after the edema itself has resolved. That persistence is worth remembering, because a patient whose edema has been successfully treated may still show exudates on examination, and their presence does not necessarily indicate active leakage. DME is more common with advanced diabetic retinopathy, although it can occur at any stage. Even patients with mild NPDR may develop significant vision loss from severe macular thickening, so you cannot use the retinopathy grade as a proxy for macular status. The macula must be assessed on its own terms in every diabetic patient. This slide contains two figures. The first is a diagram of a retinal capillary in cross-section, illustrating the breakdown of the blood-retina barrier, with fluid depicted moving out of the vessel lumen and into the surrounding neural retinal tissue, the schematic representation of everything we just described. The second is an OCT-B scan through the macula, showing the retinal layers in cross-section with pathologic thickening of the central macula and hyporeflective cystoid spaces within the retina, representing accumulated intraretinal fluid.
Having defined diabetic macular edema, we need a classification system, and the modern system is based on OCT findings. Center-involved DME, abbreviated CIDME, is edema that involves the fovea, specifically the central subfield on OCT mapping. Center-involved DME is a common cause of vision loss, since the fovea is responsible for our finest acuity. Non-center-involved DME does not involve the central subfield, and it usually does not affect vision. However, it may become visually significant if it progresses to center involvement. That possibility is why non-center-involved DME requires ongoing surveillance rather than dismissal. It is not a benign finding, but a finding that has not yet reached the location where it matters most.
The quantitative thresholds for what constitutes abnormal thickening of the 1 mm OCT central subfield vary by OCT machine, and they are on average higher in men than in women. There are two practical consequences. First, you cannot directly compare an absolute thickness value obtained on one device against the normative range of another, which is why serial imaging on the same machine is strongly preferable. Second, sex-based normative differences mean that a single universal cutoff number applied to all patients will misclassify some of them.
Before OCT became universally available, macular edema was classified clinically, and that older system, clinically significant macular edema, or CSME, is still worth knowing, both for historical literacy and because it appears on examinations. CSME is defined by any one of the following three criteria. First, retinal thickening at or within 500 microns of the center of the macula. Second, hard exudates at or within 500 microns of the center, if associated with adjacent retinal thickening. Note that the exudates alone are insufficient. Adjacent thickening is required. Third, retinal thickening greater than 1 disc area in size, located within 1 disc diameter of the center of the macula. Notice the conceptual logic uniting these criteria. Each one describes edema that is either close enough to the fovea or extensive enough near the fovea to threaten central vision. That was the entire purpose of the definition, to identify by clinical examination alone which eyes warranted focal laser treatment. CSME is an older pre-OCT clinical classification developed when stereobiomicroscopy was our only means of assessing macular thickening. Since anti-VEGF therapy has replaced focal laser as first-line treatment, the diagnosis of CSME has become less clinically relevant. Since our classification of DME is now imaging-based, let us clarify what each imaging modality actually tells us, because they answer different questions. Fluorescein angiography demonstrates breakdown of the blood-retina barrier by showing retinal capillary leakage. It visualizes the process of leakage itself as dye escapes from incompetent vessels into the surrounding tissue over the course of the study. Note that leakage on fluorescein angiography may occur without any macular thickening. For detecting macular thickening itself, the most appropriate modalities are OCT and slit lamp bioelectroscopy. OCT provides the quantitative cross-sectional measurement of retinal thickness, and stereobiomicroscopy at the slit lamp provides direct clinical assessment of retinal elevation. The practical implication is that these modalities are complementary rather than interchangeable. You use OCT to determine whether edema is present and whether it involves the center, and you use fluorescein angiography to identify the source of leakage and to assess macular perfusion. The figure on this slide is a fluorescein angiogram of the macula, showing the characteristic appearance of leakage, areas of increasing hyperfluorescence with indistinct blurred margins that expand over the course of the angiogram. We now turn to the treatment of diabetic macular edema, beginning with the decision of whether and when to treat at all. First, a principle that should be familiar by now. Ocular therapy should be combined with medical management and optimization of systemic habits. As to whom we treat, the core recommendation is to treat center-involved DME with visual impairment. Notably, treatment for center-involved DME with good visual acuity may be safely deferred and initiated later if vision worsens, a recommendation supported by trial data we will examine shortly. Several factors influence the treatment decision. Firstly, the proximity of exudates and thickening to the fovea, as discussed in a prior slide. The status and course of the fellow eye, because a patient whose only good eye is the one in question warrants a different threshold than a patient with an excellent fellow eye. The presence of high-risk PDR, risks of treatment itself, and systemic conditions or medications that may worsen edema, with, for example, thiazolidinodones, a class of medications that can exacerbate macular edema. Lastly, control of glycemia, hypertension, and hyperlipidemia. Finally, DME should be treated before PRP or cataract surgery. Recall from our discussion of PRP adverse effects that photocoagulation may worsen macular edema, and we will shortly see that cataract surgery may do the same. Treating the edema first protects the macula from being destabilized by either intervention.
Anti-VEGF agents are the first-line treatment for most center-involved diabetic macular edema, and particularly for eyes with vision loss. Corticosteroids serve as an alternative in two specific circumstances. First, in patients who are not suitable for anti-VEGF therapy, which may reflect medical contraindications, patient preference, or inability to sustain the required follow-up schedule. Second, in eyes with an incomplete response to prior anti-VEGF treatment, where the edema has persisted despite adequate anti-VEGF therapy, suggesting that mediators other than VEGF are contributing. We will discuss the specific corticosteroid options and the reasons they remain second-line rather than first-line in a dedicated slide later in this section. But first, let's review the trial evidence that established anti-VEGF therapy as first-line, beginning with the trial that changed the standard of care.
DCR.net Protocol I is the trial that fundamentally changed the management of diabetic macular edema, and it deserves careful attention. It was the first Phase 3 trial to show that anti-VEGF therapy was superior to laser for center-involved DME. The design compared several arms: ranibizumab with either prompt or deferred laser, with deferred defined as 24 weeks or more, against laser alone and against laser combined with triamcinolone alone. The ranibizumab arm improved vision more than either laser alone or laser plus triamcinolone alone. At 1 year, the visual acuity gain was 8 to 9 letters with ranibizumab, compared with 3 letters for laser alone. Two further findings are of substantial practical importance. First, the vision gains were maintained through 5 years, despite fewer injections over time, meaning the treatment burden decreases as the disease is brought under control, which is an encouraging counterpoint to the durability concerns we raised regarding proliferative disease. Second, deferred laser, given at 24 weeks or later, was as good as or better than prompt laser. In other words, there is no advantage to rushing to laser, and there may be a disadvantage. That finding is a major reason that focal laser moved from first-line therapy to an adjunctive role.
This slide presents the outcome data from Protocol I graphically, and it is worth walking through both figures. The figure is a table of outcomes stratified by treatment group, listing the 4 study arms: sham injection plus prompt laser, ranibizumab plus prompt laser, ranibizumab plus deferred laser, and triamcinolone plus prompt laser, with their associated mean change in letter score. Mean change in visual acuity score is on the vertical axis against time on the horizontal axis, extending across the follow-up period. 4 curves are plotted, one for each treatment arm. The 2 ranibizumab curves rise rapidly during the early weeks and then plateau at the highest position on the graph, consistent with the 8 to 9 letter gain we described. The sham plus prompt laser curve rises much more modestly and settles well below the ranibizumab curves, reflecting the approximately 3 letter gain. The triamcinolone plus prompt laser curve shows an initial rise followed by a relative decline, ending below the ranibizumab arms. That trajectory of the steroid arm is worth noting, an early response that is not sustained, and it foreshadows the discussion of why corticosteroids are considered second-line therapy. What I want you to take from these figures is the shape of the curves as much as their endpoints. The anti-VEGF benefit appears early, and it is durable.
The RISE and RIDE trials evaluated ranibizumab and determined that it rapidly and sustainably improved vision, reduced the risk of further vision loss, improved macular edema, and did so with low complication rates. Note the completeness of that result: improvement in vision, prevention of further loss, anatomic improvement, and safety, all in the same trial program. The VIVID and VISTA trials evaluated aflibercept and found that it produced substantial visual acuity gains compared with laser photocoagulation. Taken together with Protocol I, these trials establish a consistent and reproducible message across multiple agents and multiple study populations. Anti-VEGF therapy is superior to laser for center-involved diabetic macular edema. The next natural question, however, is whether the individual anti-VEGF agents differ from one another, and that is precisely what the next set of trials was designed to answer.
DCRC.net Protocol T addressed the head-to-head question directly, comparing visual acuity outcomes in patients receiving aflibercept, bevacizumab, or ranibizumab for diabetic macular edema. The critical insight from Protocol T is that the answer depends on baseline visual acuity. In eyes with worse baseline vision, 20/50 or worse, aflibercept was superior to bevacizumab at both 1 and 2 years.
Aflibercept was also superior to ranibizumab at 1 year, but the two were similar by 2 years. So in eyes that start out seeing poorly, agent selection matters, with aflibercept showing an advantage that is most pronounced early and most durable against bevacizumab. In eyes with only mild vision loss, 2032 to 2040, aflibercept, bevacizumab, and ranibizumab produced equivalent outcomes at both 1 and 2 years. In this group, agent selection did not affect the visual outcome. The practical implication is significant, since it means that in eyes with good baseline acuity, the least expensive agent may be a reasonable initial choice. DCRC.net Protocol AC extended this line of inquiry by comparing aflibercept monotherapy against a strategy of initiating treatment with bevacizumab and switching to aflibercept only if the improvement was subpar. Over 2 years, visual outcomes were similar between these strategies in eyes with moderate visual impairment. That finding supports a stepwise, cost-conscious approach. Begin with bevacizumab and escalate only if the response is inadequate.
We turn now to the trial that justifies the deferral strategy we mentioned earlier, the recommendation that center-involved DME with good visual acuity may be safely observed. DRCR.net Protocol V enrolled patients with center-involved DME and visual acuity of 20/25 or better and randomized them to one of 3 strategies: aflibercept, macular laser, or initial observation. Importantly, patients in both the laser and observation groups received aflibercept if their vision subsequently worsened, so this was a comparison of treatment strategies rather than a comparison of treatment against no treatment. At 2 years, there was no significant difference between the groups in the proportion experiencing 1 line or more of vision loss, and no significant difference in mean visual acuity, which was 20/20 in all 3 groups. Now consider the 2 findings that make this trial so practically valuable. In the observation group, approximately 2/3 of patients never required aflibercept at all. In the laser group, approximately 3/4 never required aflibercept. So in eyes with center-involved edema but excellent acuity, the majority never needed injection therapy during the 2-year study period. This is why we do not treat every eye with center-involved DME automatically. If we did, we would be committing a substantial majority of these patients to an intensive injection regimen from which they would derive no visual benefit, with all of the associated cost, inconvenience, and procedural risk.
Since we have now spent considerable time recommending intravitreal injections, we should address their risks. Endophthalmitis is the most feared complication, and it is rare, occurring at a rate of approximately 1 in 1,000 injections. Rare, but not zero, and given that many of these patients receive monthly injections for years, the cumulative exposure across a treatment course is not trivial. Retinal detachment is also listed among the potential complications of intravitreal injection. Finally, there is an important reassurance regarding systemic safety. Intravitreal anti-VEGF therapy has not been shown to increase thromboembolic events, in contrast to what has been observed with systemic anti-VEGF therapy.
Let us now return to corticosteroids and examine why they occupy second-line status. Corticosteroids are generally considered second-line therapy for diabetic macular edema for 2 reasons. First, they produce inferior visual outcomes compared with anti-VEGF therapy, which we saw directly in the Protocol I data. Second, they carry a higher rate of adverse effects with long-term use, most notably cataract and glaucoma. Those 2 complications are inherent to sustained intraocular steroid exposure, and in a patient population already facing multiple threats to vision, adding steroid-induced cataract and steroid-response glaucoma is a meaningful cost. That said, sustained-release steroid implants have an established role. 2 are described, the dexamethasone implant and the fluocinolone acetonide implant. Both have demonstrated 3 or more lines of visual acuity improvement in eyes with diabetic macular edema, so their efficacy is genuine. In pseudophakic eyes, steroids are a reasonable alternative to anti-VEGF therapy, as cataract development is no longer a concern. Supporting this, in DRCR.net Protocol I, pseudophakic eyes treated with steroids had visual outcomes similar to anti-VEGF therapy and outcomes superior to laser alone. So the apparent inferiority of steroids in the overall trial population was driven substantially by the phakic eyes developing cataract, although keep in mind the risk of glaucoma development or progression. Several additional DRCR.net protocols refine our understanding of the role of steroids in laser, and each answers a distinct question.
Protocol B found that focal and grid laser was more effective and caused fewer adverse effects than intravitreal triamcinolone at either 1 mg or 4 mg. Protocol I, which we have already discussed in detail, found that intravitreal triamcinolone combined with laser was inferior to ranibizumab with or without laser and inferior to laser alone. This is the finding that consolidated the second-line status of steroids. Protocol U asked a more contemporary and clinically pressing question. What should be done for persistent center-involved DME despite 6 or more prior anti-VEGF injections, the refractory eye? In that population, adding a dexamethasone implant to continued anti-VEGF therapy improved retinal thickness but did not improve visual acuity compared with continued anti-VEGF therapy alone.
Beyond pharmacologic therapy, there are two non-pharmacologic options for diabetic macular edema: macular laser photocoagulation and pars plana vitrectomy. Let us begin with macular laser. In the current era, macular laser photocoagulation is primarily an adjunctive treatment, reserved for eyes that are resistant to anti-VEGF therapy. However, it may still serve as first-line therapy in two specific situations. The first is non-center focal leakage that is amenable to laser, that is, a discrete leaking lesion away from the fovea, where laser can address the source directly without threatening central vision. The second is in patients who are poor candidates for anti-VEGF therapy, whether because of medical instability or an inability to adhere to frequent follow-up. This is the same adherence consideration we raised when comparing PRP against anti-VEGF for proliferative disease. The historical evidence for macular laser comes from the ETDRS. In that study, focal and grid laser applied to patients with clinically significant macular edema reduced the risk of moderate vision loss, increased the chance of vision improvement, and caused only minor visual field loss. Critically, however, the ETDRS demonstrated no benefit for diabetic macular edema that did not meet CSME criteria, which is precisely why the CSME definition we reviewed earlier was constructed as it was. It defined the population in which laser and other treatments had proven benefit.
Let us review how macular laser is actually performed, since the technique is quite different from the panretinal photocoagulation we discussed earlier. Fluorescein angiography and OCT thickness maps may be used to guide treatment. The angiogram localizes the leaking microaneurysms, and the thickness map identifies where fluid has accumulated. As to parameters, a yellow or green laser is used with a spot size of 50 to 100 microns and a burn duration of 1/10 of a second or less, with spots placed 1 burn width apart. Contrast these parameters with PRP, where we used a 500 micrometer spot and placed burns half a burn width apart. Macular laser uses a much smaller spot and wider spacing because we are treating adjacent to the fovea and the margin for error is correspondingly narrow. For diffuse leakage, the approach is to treat all leaking microaneurysms that lie at least 500 microns from the foveal center and at least 500 microns from the temporal disc margin. Those two 500 micron exclusion zones protect the fovea from direct injury and protect the papillomacular bundle from scotoma formation. Treatment may be repeated every 16 weeks, continuing until either the retinal thickening resolves or all leaking microaneurysms have been adequately treated. Finally, micropulse therapy, which uses subthreshold intensity burns, may be as effective as standard macular laser while reducing collateral damage to the surrounding retina. The concept behind micropulse is to deliver a therapeutic thermal stimulus below the threshold that produces a visible destructive scar while maintaining structure and function of surrounding tissue. Because macular laser is delivered close to the fovea, its adverse effects are correspondingly consequential, and this profile is part of why it has yielded non-first-line status compared to anti-VEGF therapy. The adverse effects include paracentral scotomas, corresponding to the laser scars themselves, transient worsening of edema or of vision immediately following treatment, laser scar expansion, in which the atrophic scar enlarges over time and may eventually encroach on the fovea, subretinal fibrosis, choroidal neovascularization arising at sites of treatment, and inadvertent foveal burns, which are the most feared and are immediately and permanently vision limiting. Note that laser scar expansion is a particularly insidious complication because a burn that was safely distant from the fovea at the time of treatment may not remain so over subsequent years. That is one rationale behind the 500 micrometer exclusion zone we previously described. There are also two predictors of poor visual outcome after macular laser that are worth knowing.
The first is macular ischemia, defined by extensive perifoveal capillary non-perfusion. The second predictor is hard exudates involving the fovea, since lipoprotein deposits at the fovea are associated with photoreceptor damage that persists even after the edema resolves.
The second non-pharmacologic option for diabetic macular edema is pars plana vitrectomy. PPV, performed with or without internal limiting membrane peeling, may improve retinal thickening, and it is particularly worth considering when vitreomacular traction or an epiretinal membrane is present. That indication is mechanistically logical. If a taut posterior hyaloid or an epiretinal membrane is exerting tangential traction on the macula, no injection will relieve that mechanical force, and surgical removal addresses a problem that pharmacotherapy cannot. However, PPV is not associated with a consistent improvement in visual acuity, and here again we encounter the dissociation between anatomic and functional outcomes that has recurred throughout this lecture, with Protocol W, with Panorama, and with Protocol U. Accordingly, vitrectomy is typically not a first-line treatment for diabetic macular edema, and further studies are needed to define its role more precisely. The reasonable clinical position is that PPV should be reserved for eyes with a clear mechanical component to their edema, rather than applied broadly to eyes with diffuse leakage-mediated edema that would be better served by anti-VEGF therapy.
Our final slide concerns cataract surgery in diabetic patients, which requires special consideration because cataract surgery may worsen the severity of both diabetic retinopathy and diabetic macular edema. Furthermore, any history of DME may predispose a patient to postoperative macular edema, so the past history matters, even if the macula appears dry on the day of surgery. This is why, as we noted earlier, DME should be treated before cataract surgery. Preoperative management therefore includes several considerations. An anti-VEGF or steroid injection may be given to stabilize the macula before surgery. Systemic optimization of glycemic control, blood pressure, and lipids should be pursued, the same three systemic pillars we established at the beginning of this lecture, and PRP should be considered in patients with severe NPDR or proliferative disease in order to address the proliferative drive before the eye is subjected to surgical stress. There are also three important intraoperative considerations. First, perform an adequate capsulorhexis to reduce the risk of anterior capsule phimosis. Second, avoid silicone intraocular lenses because they may fog during a future vitrectomy. And given everything we have discussed today about vitrectomy indications in diabetic eyes, the probability that this patient will one day require vitreoretinal surgery is far from negligible. Third, avoid multifocal intraocular lenses in patients with macular disease because they may complicate future retinal surgery and produce unsatisfactory visual outcomes in an eye whose macular function is already compromised.
That brings us to the end of Chapter 5. Let us close by drawing the threads together. Everything we covered today descends from a single cascade. Chronic hyperglycemia injures the retinal capillary endothelium and its parasites, producing capillary occlusion and non-perfusion. Non-perfusion produces ischemia. Ischemia drives VEGF, and VEGF produces both the vascular leakage that gives us diabetic macular edema and the neovascularization that gives us proliferative disease with all of its complications. From that foundation, we built a staging system from mild NPDR to PDR with high-risk characteristics. We grounded each treatment decision in the trials that established it: the DRS, the ETDRS, the DRVS, Protocol S, I, T, Protocol V, and the rest. Thank you for your attention, and I hope this framework serves you well, both in the clinic and on the examination.